Thank you for the introduction, Larry. So yes, hello everyone, my name is Katie, and whilst I was a paediatric trainee in Liverpool, it's been 3 years of hard work on this review, so I'm actually now based in Edinburgh in Scotland. So I have a real interest in cystic fibrosis, but actually my passion is for exercise and prevention medicine, and I'm one of the paediatric trainees here in Scotland. So as I said, this review's taken the best part of 3 years, so I'm absolutely thrilled to be sharing it with you all today. And thank you to Thomas and Dawn for inviting me along. So, as all of you know, airway clearance techniques are an integral part of CF management, especially Brenda, to aid mucociliary clearance and maintain respiratory health in CF. Currently, there are many different forms of airway clearance techniques employed, and 5 other Cochrane reviews have already been completed comparing these, all of which conclude non-superiority. As non-superiority exists, there is no globally agreed definitive treatment strategy for the use of airway clearance techniques and their prescription. Exercise is thought to be a suitable alternative, although the evidence surrounding exercise to aid secretion has not fully been assessed. Currently, we use exercise as an adjunct rather than it in isolation because of its efficacy. As mentioned in an earlier presentation today, exercise has numerous additional health benefits. For example, improving glycemic index, maintaining weight, bone health, mental health and well-being, and aerobic capacity, which is thought to be one of the best predictors of survival for patients with CF. There's also recent evidence that's been published by both the Australian and UK group that between 44 and 54% of patients are choosing to substitute airway clearance techniques with exercise, suggesting a potential preference for this mode. In addition, as survival increases, patients are really keen to incorporate treatments that are more in keeping and in fitting with their chaotic and busy lives, and that are less of a treatment burden. This has led to patients with CF asking the question, can exercise replace chest physiotherapy? Which, as mentioned earlier, is one of the top 10 questions identified by the James Lind Alliance. So with this in mind, by undertaking this Cochrane review, we had 3 main aims. We wanted to evaluate the efficacy of exercise as an airway clearance technique. We wanted to compare this modality of clearance with current, more conventional methods. And we aimed to address and answer the question, can exercise replace chest physiotherapy? To do this, we searched the CF Cochrane Trials Register and online clinical trials registries. We selected randomized control trials comparing exercise alone or in combination with another airway clearance technique for at least 2 treatment sessions, and data were independently extracted and assessed for risk of bias using the grade system. The outcomes that we were primarily interested in were lung function, exercise capacity, and quality of life. The secondary outcomes are also listed here for your reference. As you can see, the results of our search are presented here in the form of a prisma diagram. Only 4 studies were deemed eligible for inclusion, 2 of which were abstracts only. These compared exercise to postural drainage and percussion, active cycle of breathing technique, and underwater PEP. A total of 86 participants, both children and adults, and those that were clinically stable and hospitalized inpatients were included. Due to the diverse study design and heterogeneity between the studies, unfortunately, this did not enable meta-analysis of the results. This is just a summary slide of the characteristics of the 4 included studies. In terms of design, you can see that they were all randomized. 2 were parallel and 2 were crossover studies. The 2 crossover trials did not describe a washout period. Trial duration varied between 4 days and 6 months, and all trials were single center. In terms of the participants, 3 trials were conducted in patients that were clinically stable, and another trial recruited patients that were admitted for an acute respiratory exacerbation. One trial was conducted in children alone, and the others included both children and adults. In terms of the intervention, 2 of the trials compared exercise to postural drainage and percussion, 1 to active cycle of breathing technique, and the final one to underwater PEP. 2 trials compared exercise in combination with airway clearance technique. 1 trial compared exercise alone to physio, and 1 trial had several arms which evaluated both exercise alone and in combination with an airway clearance technique. In terms of the outcomes, there was huge diversity in terms of the outcomes measured. Regarding the primary outcomes, 3 trials reported FEV1, 1 trial measured exercise capacity, and none of the included studies evaluated health-related quality of life. Unfortunately, due to the diversity in both the study outcomes and the characteristics, as I said, a meta-analysis was not able to be performed, so the results in this review are largely narrative. In terms of lung function, 3 trials reported an improved baseline FEV1, with only 1 trial reporting a significant between-group difference, favouring exercise. 1 trial measured exercise capacity, and in this trial, no significant differences in work rate peak were observed. However, peak heart rate to peak load ratio improved significantly in the exercise group. Health-related quality of life was not a reported outcome. However, 1 study did use a non-validated questionnaire, which reported more participation in school and less fatigue in the exercise group compared with the physiotherapy group. Despite Brenda's large list of musculoskeletal adverse events, there were no adverse events reported in any of these studies, especially in terms of oxygen saturation and heart rate monitoring. In terms of participant preference, 1 study patient preferred any arm with physiotherapy more than exercise alone. However, another study reported that although patients perceived exercise to be more fatiguing, they also found it the more enjoyable choice. In 2 trials, there was no between-group difference observed in sputum weight. However, 1 trial did report a significantly less sputum production in the exercise group. Hospital admissions were less in the exercise group of 1 study compared with physiotherapy. However, no significance value was reported. And the same trial reported no difference in extra antibiotic days between the 2 groups. There were many limitations of this evidence, and the quality of evidence is discussed in greater detail in the review. But overall, most of the outcomes were assessed to have a moderate to high risk of bias and low quality of evidence. Studies were conducted over 30 years ago and were short in duration. As anticipated, we identified few studies that evaluated exercise as an independent intervention. The crossover studies had no significant washout period and did not examine the order of effect. In our protocol, we had aimed to take the results of the first arm of the crossover trials, but presentation of data within these trials did not allow this. Trials were also inadequately powered, so evidence of no improvement should be carefully regarded, as power is very important in investigating the effect of no difference. There was also very limited evidence in terms of baseline characteristics and reported patient disease severity. So it's very difficult to know the applicability of our results to the CF population as a whole. In summary, this review completes the series comparing different modes of airway clearance techniques for people with CF. Previous reviews conclude non-superiority, which is consistent with this review. Considering both the primary and secondary outcomes assessed, there is no evidence to suggest that exercise is an inferior mode of airway clearance for respiratory health parameters compared with the more traditional techniques employed. And due to the lack of evidence available, we cannot definitively answer the JLA question. However, exercise does confer a lot of health benefits, but it's unclear whether this is equivalent to other more conventional modes. As Nathan suggested, more research is needed, and longer-term studies are needed to address this question. Interestingly, our review discussion mirrors a lot of the content and themes discussed in today's brilliant talks. With the recent introduction of and availability of modulators, the landscape of CF is drastically changing, and management and therapy really need to reflect this. Patients, particularly children, are less productive, which brings into question the overriding need, if any, for airway clearance techniques in general. As patients with CF are living longer, treatment burden is becoming more apparent. So our care really needs to shift towards maintaining lung health and reducing treatment burden. Exercise in theory is an appropriate alternative. However, the challenge for us as clinicians will be feeling comfortable with demedicalizing care and an inability to be prescriptive about this type of therapy. Research outcomes need to reflect the changing shape of CF care. Instead of previous important quantitative outcomes like sputum weight, our group feel that outcomes should be more patient-centered, such as health-related quality of life and patient preference. And finally, as this is an empty review in terms of the quantitative data, the bulk of the discussion in the review and time with the authors has been drafting an optimal trial design to answer this question. So I invite any of you to take this trial design forward. I'd like to really thank the co-authors of this review, Adam Walsh, Kate Regan, Zoe Johnson, my supervisor, Professor Kevin Southern, and most importantly, Nikki Janka, who's our managing editor of the CF review group. All of these guys have been an incredible support and help throughout the last 3 years. I'd like to thank you all for listening and invite any questions.